So the basics are going to be boring because of two reasons. One is it's all physics. We are all doctors because we did not like physics and maths. So ECG is basically physics. It is basically physics. Many of this ECG interpretation is done by basic physical principles. ECG machine itself a physical instrument. It is a galvanometer. That's why it is going to be boring. But all basics are always difficult to understand. That's why it is going to be boring. But nevertheless, understanding the basics form the foundation stone for your advanced ECG learning. So first of all, we are going to look at the conduction system of the heart. The conduction system of the heart is going to be very important because we know where the impulse is going to be produced, how it is going to travel to the myocardial cell. So that's what it's important. So the electricity for the heart is produced by the primary pacemaker of the heart, which is called sinus node, which is situated between the superior vena cava and the right atrium. The sinus node is called the primary pacemaker of the heart because it is the only area in the heart which can produce the fastest spontaneous cardiac impulses. As you can see, no other portion in the heart can produce more impulses than the sinus node. And also the sinus node can produce an impulse spontaneously without any stimulation. It keeps on producing the impulse. It can produce the fastest, it is spontaneous. That's why the sinus node is called primary pacemaker of the heart. Whereas many of the other areas in the heart are able to produce some electrical impulses, but at much lower rate than the sinus node. In the event of sinus node is not producing an impulse, or the sinus node the impulse is not reaching the ventricle because of some block in between, these pacemaker, either a His bundle or the junction or the myocardial cells in the ventricle, can take over the heart so that the heart does not allow to go in for a Stokes alarm attack or complete cardiac standstill. So these are called secondary pacemakers of the heart. So these are like generators. When the power fails, the generator takes over. So as long as the power is there, it is the power keeps on working. So this similarly, the sinus node is there, it keeps on working. If the sinus node impulse is able to reach the ventricle, it is the primary pacemaker of the heart. If the sinus node impulse is not produced or it is not reaching because of any block in between, it is either the junction, the atrioventricular junction or the ventricle will start producing an impulse, but this impulse is going to be much less than what the sinus node produces. So these two pacemakers are called secondary pacemakers of the heart. So the secondary pacemakers of the heart, like generators, they are going to prevent a cardiac standstill in the event of sinus node failure. If you look at the action potential is actually the recording of the electrical activity of individual muscle cells in various portions of your heart. For example, you can look at the sinus node action potential. You can see that spontaneously the diastolic depolarization rises to reach the threshold potential to fire an action potential. So this spontaneous rise is the reason for the sinus node to produce the spontaneous electrical activity at much faster rate. Whereas if I can look at all the other cells, they do not have such a rapid slope of the spontaneous diastolic depolarization. That's why the sinus node remains the primary pacemaker of the heart because of faster spontaneous diastolic depolarization. Then once the sinus node produces the impulse travels through the atrium and travels through three interatrial pathways to reach a very important area in the heart, which is called atrioventricular node. So here the impulse from the sinus node reaches the AV node through the atrium itself as well as through intraatrial pathways. The atrioventricular node is a speed breaker. It's a very remarkable area in the whole body because it is the only area in the body which can delay the impulse without reducing the amplitude of the impulse. The power of the impulse is not reduced, but only the speed is reduced. So many other areas will reduce the speed and amplitude, but AV node reduces only the speed and not the power and not the amplitude of the electrical impulse which is coming from the sinus node. There are two reasons why the AV node is very important. One is, as you can see, why should it delay the impulse? It can just conduct from the sinus node to the ventricle. But once it delays, the AV node delays it because, as you know, the atrium contracts in later part of your diastole. It is the last part of the diastole, the atrium contracts. It is because when the atrium contracts, it gives that extra end diastolic fiber stretch to the myocardium before the myocardium contracts. You can see that. So this end diastolic fiber stretch contributes 30% of our cardiac output, which is Starling's law. Starling's law says the effect of contraction depends upon the end diastolic fiber length. So if you have longer end diastolic fiber length, you have effective contraction. So the atrium, when it contracts at the last part of diastole, just before your contraction, it gives that extra stretch to the myocardium so that your next contraction is effective. Thereby, it contributes to 30% of our cardiac output. Imagine my sinus impulse is rapidly traveling through the AV node to the ventricle. As the atrium is contracting, the ventricle also will start contracting. So you will not have the full benefit of the atrial contraction. So the AV node delays the impulse so that the atrium completes its contraction, pushes all its blood into the myocardium. You have enough end diastolic fiber length, so your effective contraction is there. So that's why to allow the atrium to complete its contraction, the AV node delays the impulse. The next important aspect of the AV node is when the atrium is beating at a faster rate, like atrial fibrillation, it is beating around 300 or 400 per minute. Imagine this 400 impulses coming to the ventricle. The ventricle will start beating 300, 400 per minute. You will have effective loss of cardiac output. What the AV node does is, although the atrium is beating 400 per minute or 300 per minute, it will allow only 150 to 170 impulses to the ventricles. So the AV node protects the ventricle from a rapid supraventricular arrhythmia. So that are the two important aspects of AV node: delay the impulse and protect the ventricle from a rapid supraventricular arrhythmia. Once the AV node delays the impulse travels through the bundle of His and through the left bundle branch to the left ventricle and to the right bundle branch to the right ventricle. The left bundle branch has got two divisions, left anterior vesicle and left posterior vesicle. Because the left ventricle is the most powerful chamber in your heart, because it is going to pump to the entire systemic circulation. So that's why it needs two wires, it needs two arteries. It has got left antedescending artery, circumflex artery, and it needs two wires like anterovesical, posterior to supply the current. The right ventricle is little weaker chamber, it is supplied by the right bundle branch. So once this bundle branches, once it divides into anterovesical and posterior and the right bundle, they divide into very, very small twigs called Purkinje fibers. So the end result is a Purkinje fiber. The Purkinje fiber supply individual cardiac myocyte. It is just like the current is coming from a major powerhouse with the big wires, and the wire becoming smaller and smaller and supplying all our lights and fans with a small wire. Similarly, the sinus node produces the electrical impulse. It travels through the big wires, and it ultimately the small twigs of Purkinje fibers supply our individual cardiac myocyte. So this way, the impulse which is produced at the sinus node ultimately reach the myocardial cell. You must also understand what is the conduction velocity of each one of these areas in the heart. If you look at the AV node is the slowest conducting area in the heart because it is going to delay your cardiac impulse. It conducts at the speed of 200 millimeters per second. The fastest conducting area in the heart is the Purkinje fibers. They are called specialized conduction system. They are called specialized conduction system because it conducts at the speed of 4,000 millimeters per second. Such a rapidly they conduct the impulse to the myocardium. That's why ventricular depolarization, the whole ventricular depolarization is over within 0.08 seconds because of the rapid conduction by this specialized conduction tissues of the heart. Whereas the myocardial cell, the ventricular myocardial cell conduct at the speed of 400 millimeters per second, which is 1/10 of specialized conduction tissue. So this is very important to understand what's happening in bundle branch block and so on. Just remember, it is 200, 4,000 and 400 depending upon AV node, the specialized conduction system of Purkinje and also the ventricular muscle. So once the sinus node produces an impulse, three interatrial pathways, AV node delay, then right bundle branch and the left bundle branch. Left bundle branch got two divisions and the Purkinje fibers. So now we have reached the myocardial cell. Now we must see how this myocardial cell responds to the electricity. Now the myocardial cell has received the electricity through this conduction system. This electricity has reached the myocardial cell. Now we will see how this myocardial cell is going to respond to this electricity. For example, you can also see the conduction speeds. For example, it takes only 30 milliseconds for the sinus node impulse the AV node. whereas the AV node delays the impulse and the conduction through the AV node takes 130 milliseconds. And from the AV node to the myocardial cell, it takes once again only 30 milliseconds because of this rapid conduction through the specialized conduction system. So the total atrioventricular conduction time is less than 200 milliseconds, in other words 0.2 seconds. It's less than 0.2 seconds. But the majority of this atrioventricular conduction, the main delay is happening only at the AV node. Whereas atrium sinus node to AV node only 30 milliseconds. From the AV node to the myocardial cell is only 30 milliseconds. So majority of this 200 milliseconds, the AV node is contributing as a delay. So this is your conduction velocities through this conduction speeds through the various conduction pathways. Now we look at so this is your Purkinje fibers which are supplying, see all these are individual myocytes. So each one of these myocytes are supplied by twigs of the Purkinje fibers and produce the stimulation of the myocyte. So now we are going to see the two big terms, the depolarization and repolarization. The cardiologists are the most intelligent people and smart people. Why? Because they'll use big terms so that nobody will come near cardiology. So when you open the textbook and see depolarization, you will close the book and go for a movie, right? So we'll talk big terms, depolarization, repolarization, vector. So all these are these carrying names. So we'll see what's happening to the depolarization. So please remember, each one of your myocardial cell is like a battery cell. Your AAA or AA battery cell, which has got a polarity, which is a positive polarity, which has got a negative polarity. Up is positive, low is negative. Similarly, imagine your cardiac myocyte is like a battery cell. It has got a polarity outside, it has got a polarity inside, right? Polarity outside and polarity inside. In a resting state, the resting state is now the myocardial cell is not stimulated. The electric current has not reached the myocardial cell. It is at resting, which is called, otherwise called, it is a polarized state. Resting state is called, otherwise called polarized state. At this stage, the outside cell is positive, inside cell is negative. So just like your battery cell, outside cell is positive, inside cell is negative. Why it is positive? Why outside cell is positive? Because at a resting state, the positive charge ions are in higher concentration outside when compared to the positive charge ions inside. That's all, very simple reason. Positive charge ions like sodium and your calcium, all these things are higher in concentration outside. That's why it is positive polarity outside, negative polarity inside. So this is at the resting state. Once the current comes and stimulates this myocardial cell, what's happening? So what happens is, the current stimulation changes the permeability of the cell membrane and allows the positive charge ions to go inside the cell. So this is what the current does to the myocardial cell. So once the positive ion go inside the cell, what will happen to the inside cell? Now the inside cell become positive, outside cell become negative. So this is the response of a myocardial cell to the electricity. It changes its polarity. From outside cell positive, it becomes inside cell positive. This is depolarization. Depolarization is nothing but the response of a myocardial cell to the electric current. How it responds? It responds by changing its polarity. That's all. So this is called depolarization. So once the current comes and changes this polarity, the cell cannot remain in the same state. The cell cannot remain in the same depolarized state because sinus node is keep on producing the impulse, isn't it? It is producing at the rate of 60 to 100 per minute continuously. So the next sinus impulse is coming. The next sinus impulse also should stimulate this myocardial cell. For that, the cell has to come to the original resting state. Then only it will be in a position to respond to the next sinus impulse which is coming. So that's why the cell has to come to the original state of polarized state, isn't it? What is the original state of polarized state? Outside cell is positive. So from the inside cell positive, now what happens is the positive ions move out of the cell. In a depolarization, positive ions came inside the cell. So inside the cell became positive. Now to go back to the original state of outside cell positivity, the positive ion should move out of the cell. So once the positive ion moves out of the cell, original outside positivity restored and you have negative inside. So this process of recovery from the depolarization is called repolarization. It is called repolarization. So the depolarization and repolarization is nothing but the response and the recovery of the myocardial cell for the electric current which is coming. Very simple terms. So how it depolarizes? Depolarizes, inside cell becomes negative, inside cell becomes positive, outside cell becomes negative. So the recovery is repolarization. So please remember, we will always have confusion. At a resting state, outside is positive or negative. Always will have that confusion, isn't it? So I used to remember OP. In a resting state, it is OP. Outside cell is positive. Outpatient. In outpatient, we used to take rest now. So at a resting state, outside cell is positive. So OP is rest. OP is outside positive, is a resting state, depolarized and repolarized. So your ECG is nothing but recording of depolarization and repolarization in a waveform. For example, you want to record this depolarization, repolarization in a particular waveform on an ECG paper, that is your ECG. ECG is nothing but recording of various areas of your myocardium on a ECG paper in waveform is ECG. So now we see that I am showing the outside cell positivity, outside cell polarity. This is outside cell polarity, whether it is depolarized state or repolarized state. Outside cell is positive, depolarized or repolarized. All is in depolarized because outside cell is positive. Now we can see that all outside cell has become negative. So what's happening here? All the cells now are depolarized. So depolarized, outside cell becomes negative. In a polarized or resting state, it becomes positive. So once again, if this outside negativity becomes positive outside, it is called repolarization. So depolarization and repolarization. So now we must also see that how this depolarization wave travels and repolarization wave travels. As you can see that, now you can see that this is endocardium which is closer to the cavity and this is epicardium which is closer to the pericardium. So epicardium is the outer cover and the endocardium is the inner cover of the heart. Normally, so as you can see, the depolarization produces a wave which we record as ECG, repolarization produces a wave which we record as ECG, isn't it? So this repolarization is recorded as a ECG waveform on your ECG paper. You can see it here when all this is the repolarizing state is happening. Now look at the depolarization. All my outside cell from endocardium to epicardium, all my outside polarity has become negative. So this is a depolarized state. When all my outside polarity becomes positive, it is a repolarized state. So whenever I record depolarization as a positive waveform, I record repolarization as a negative waveform because they are opposite electrical processes, isn't it? So whenever I record depolarization as positive, the opposite process I record as negative normally. So the depolarization travel from endocardium to epicardium. Please remember that there are certain statements you cannot forget for your life. One of the statement is depolarization starts from endocardium to epicardium. The direction of depolarization is from endocardium to epicardium. So when your endocardium to epicardium depolarization produces one wave and repolarization produces an opposite wave. This is, it's a logic. This is easily understandable. But have you seen ECG accidentally sometime? Have you seen ECG sometime? No? So whenever you see a ECG, so in ECG, the QRS represent the ventricular depolarization and T wave represent ventricular repolarization. So now we translate this repolarization into a ECG waveform. So the QRS complex is depolarization, T wave is repolarization. That means in QRS, during the depolarization, during the QRS complex, outside cell becomes negative. During my T wave, outside cell becomes positive again. So that's what we have seen. Now, when you see the ECG, whenever what is logically I must have, when my QRS is upright, what should be my repolarization? The T wave should be negative because when the depolarization is positive, we saw the repolarization has to be negative. So if my ventricular depolarization, we see that depolarization produces the QRS complex and the repolarization produces the T wave. Both are in the same direction because of opposite directions. Now the next term you have to understand will be called vector. The vector is the ultimate direction of the net cardiac impulse. For example, as you can see, the heart has got so many surfaces. It has got a medial surface, lateral surface, anterior surface, posterior surface. So many surfaces are there. A single sinus impulse is going to depolarize all the myocardial cell at a single instant. That means your impulse has to go to various directions to depolarize the various areas of my heart. Isn't it? That means a single impulse has to travel all over my heart to various directions. But although it is traveling in various directions, depending upon where my major muscle mass is, ultimately in a single direction, the net cardiac impulse will travel. In a normal heart, which ventricle has got the maximal muscle mass? The left ventricle. So although the impulse is going to the right, going posteriorly, going anteriorly, my major muscle mass ultimately will pull my net vector towards it. Isn't it? So that's why it is called the vector is the net direction, amplitude of the resultant cardiac impulse. Direction and amplitude of the resultant cardiac impulse. So remember a river. River is produced in the hills and it is going across the gradient, along the gradient to merge with the sea. Isn't it? That is a river. As it is traveling, it is giving so many tributaries, so many branches, but ultimately it is traveling in single direction along the gradient. Similarly, the sinus node which is produced will be traveling towards a major muscle mass, although it is giving so much of direction of impulses which will depolarize the other areas of the heart. In a normal heart, the left ventricle has got the major muscle mass. That's why your major cardiac impulse will travel down and towards your left. Down and towards your left. Sinus impulse is here, sinus node is here. So it will travel down and towards the left, towards your left ventricle in a normal heart. So this is the vector. This is vector is nothing but the resultant cardiac impulse. For example, in some abnormal situation, your right ventricle may become hypertrophied. The right ventricle muscle mass may become more than your left ventricle muscle mass. There, your net cardiac impulse will travel towards the right rather than towards the left. So seeing that the net impulse is going towards the right, you know that my right side is abnormal. The right ventricle is producing more muscle mass than my left ventricle. So what is the condition which is producing this type of change in the direction of depolarization? So that's why the net vector will help you to understand many of the disease conditions. So now we are going to see how our PQRST is going to be produced. So now we know what is depolarization, repolarization, what is happening inside my cell and so on. Now we are going to derive all our PQRST. Once the sinus node produces an impulse, impulse comes out of the sinus node to first depolarize the atrium. So that produces the first wave in the ECG which is called P wave. There is no way you can see the sinus node activity in the ECG. If somebody asks you to show the sinus node impulse, sinus node activity on my ECG, it is not seen in a surface ECG. We infer the sinus node activity by looking at the atrial depolarization. The first wave we see in the ECG is atrial depolarization, by which we imagine that the sinus node produces an impulse, it has come out of the sinus node and it has depolarized the atrium. So that is the first wave we see in the ECG paper, right? That is the P wave. So once it comes, it produces the P wave. So P wave is due to what? Atrial depolarization. P wave is due to atrial depolarization. Once the impulse reaches the AV node, what the AV node does? It delays the impulse. So now there is no depolarization, there is no repolarization. The impulse has reached the AV node is delaying the impulse. That means it's a flat line. Only when there is a repolarization, the impulse will be positive or negative. When the impulse is traveling without anything, it will be a flat line. So the PR segment, you see is due to the AV nodal delay. The PR segment you see is the AV nodal delay. Then after that, when the impulse comes out of the AV node, rapidly conducts through the Purkinje fibers and depolarize your ventricular muscle. The depolarization of the ventricular muscle is seen as QRS complex. QRS complex indicate ventricular depolarization. So atrial depolarization, AV nodal delay, ventricular depolarization. After that, once the ventricular depolarization occurring from which area to which area? Endocardium to epicardium. It is not as if as soon as the depolarization is over, repolarization is starting. What happens is the depolarization reaches the epicardium, there is a small gap, then only repolarization starts from the epicardium to endocardium. That small gap is ST segment. Here also, depolarization is not happening, repolarization is not happening, it is only the flat line. So that is the ST segment. So ST segment is the gap between the end of depolarization to the beginning of repolarization. So that is the ST segment. So that is your ST segment. Now you have the ST segment. After the QRS complex, you have the ST segment. Then the repolarization starts from the epicardium to the endocardium, resulting in a T wave which is upright in direction with the QRS complex. The T wave represents ventricular repolarization. So once this is over, after that, the impulse, the myocyte is now ready. It is outside cell has become positive again, till the next sinus impulse comes and produces the P wave and so on. So till the end of T wave to the next beginning of the P wave is called TP segment. The TP segment is the end of one cardiac impulse and the myocardium is waiting for the next cardiac impulse if your TP segment. Here also no depolarization, repolarization is happening, so it's a flat line. So you have three flat lines. One is the PR segment, AV nodal delay. Second is the SC segment, which is the gap between the depolarization and repolarization, and the TP segment, where one impulse is over and the myocardium is waiting for the next impulse. And you have three positive waves, three waves, P wave, atrial depolarization, QRS complex, ventricular depolarization, T wave, ventricular repolarization. So three waves, three flat lines. That's all the ECG. Finished. All the ECG is over. Three waves and three flat lines which are produced. So once again, at the end of T, then once again the same cycle begins from the atrial depolarization and so on. So this is your how the derivation of your ECG from our depolarization, from the basic cardiac cell physiology, how it translates into ECG recording on the ECG paper. You must ask me one question. You must ask me one question. Where is atrial repolarization? I told you atrial depolarization, ventricular depolarization, atrial repolarization. But I not tell you any wave for atrial repolarization. Atrial repolarization is a very small wave. As you can see, atrium itself is a small, as you can see, the atrial depolarization itself is producing a very small wave. The atrial repolarization is usually within the QRS complex. So usually in a surface ECG, simultaneously happening. Atrial repolarization is happening, ventricular depolarization is happening, which is a big event. Ventricular depolarization is a big event. So the atrial repolarization is submerged inside that QRS complex. So in a normal surface ECG, you do not see the atrial repolarization. Now we can see the sinus node has produced an impulse, atrial depolarization P wave, AV nodal delay PR segment, ventricular depolarization QRS complex, the gap is the ST segment, ventricular repolarization is the T wave, and the T wave is upright with the QRS complex because the repolarization travels from epicardium to endocardium and depolarization travels from the endocardium to epicardium. So this is your derivation of your PQRST complex. Any doubts? So this is where for this, for example, this PQRST, you have to see all the surfaces. You must see what's happening in inferior surface, whether depolarization, repolarization is normal. My anterior surface, depolarization, repolarization is normal. My lateral surface, whether depolarization, repolarization is normal. That's why you look at various leads to look at the various surfaces to make sure in each one of these areas your depolarization and repolarization are normal. If it is abnormal, why it is abnormal? What disease process is producing this abnormality is the whole ECG reading. How this is happening, how this is altered, and why it is altered. And how it is altered is the ECG reading. Now the sinus node impulse, this diagram will be keep on seeing again and again. Sinus node produces an impulse, AV nodal delay, rapid conduction through the Purkinje system, and ventricular depolarization, revolarization. So you have derivation of PQRST complex. Then I just want to tell you the relationship between the action potential and the ECG. The action potential, as you can see, actual recording of the electrical activity at the myocardial level. This is at the ECG level. On the surface, you record that. At the myocardial level, as you can see, inside cell is negative. Because the sodium ion enters the cell becomes positive. This is the depolarization. And the plateau is maintained by, once again, a positive ion of calcium entering in the cell. And the repolarization is because the positive ion of potassium leaving the cell. So, I can translate that into ECG complex. So, whenever you have the QRS complex, it represents the upstroke of action potential. Whenever you have a ST segment, it indicates the plateau phase where the calcium enters. Whereas when you see a T wave, it is a potassium leaving the cell. That's why in the electrolytes and ECG, abnormal sodium currents will produce a QRS complex abnormality. Abnormal in calcium will produce a ST segment abnormality. Abnormal in potassium will produce a T wave abnormality. You can see that how easily we know that this relationship between the ECG and electrolyte. So abnormal conditions, whichever alter the action potential upstroke, will alter the QRS complex. Your tricyclic antidepressants will produce widening of QRS. Why? It alters the sodium entry into the cell. Your hypocalcemia and hypercalcemia alter the ST segment because the ST segment indicates the plateau phase of action potential. And your hyperkalemia and hypokalemia affects the T wave because the T wave represents the repolarization phase where the potassium is leaving the cell. So this is your translation of your action potential into your ECG waveform. How this is going to help us in contraction? For example, once my electricity stimulates my myocardial cell, you can see that my action potential is going to change many permeability of my membranes, cell membranes. Because of that, sodium and calcium enters the cell, and the calcium entry stimulates sarcoplasmic reticulum to release the free calcium, and the free calcium is going to remove the inhibitor of actin myosin sliding, and the heart contracts. So this is the translation of your electrical activity into your mechanical activity. How this electricity ultimately produces the cardiac contraction. The electricity is going to change the permeability, alter the membranes so that the many ions enter the cell and they ultimately produce the actin myosin sliding. And taking the calcium away from the actin myosin will produce the relaxation. So this happens because the electric current is coming. If the electric current is not coming, your myocardial contraction cannot happen. So this is called electromechanical association. Electricity is being converted into your mechanical contraction. So after that, the next important thing you have to understand and remember for your life, the first thing is depolarization is endocardium to epicardium. Repolarization is epicardium. So this you should not forget. The second important principle you have to understand is if an impulse comes towards an electrode, the positive pole of an electrode, that electrode will record a positive complex. By positive complex, we mean anything above the baseline. Any activity above the baseline, we call that positive wave. Any activity below the baseline, we call as a negative wave, which is equal positive and negative, we call them as equiphasic complex. It's called equiphasic complex. So whenever an impulse comes towards an electrode, it records a positivity. Impulse going away from the electrode, it will record a negativity. The impulse is perpendicular. If one portion is coming towards and one portion is going away, it will record an equiphasic complex. So please remember this. Impulse coming towards positive, going away negative. Perpendicular is equiphasic. So this you can see, here is my electrode. If an impulse comes towards my electrode, this electrode will record a positive QRS complex. If the impulse is perpendicular to me, this will record an equiphasic complex. If the impulse is going away from this electrode will record a negative complex. Be it P wave, be it QRS, any wave. For example, you see a particular lead, for example, AVR, your P wave is negative. That means you infer that the P wave is going away from my AVR. If L1, the P wave is positive, you infer the P wave is coming towards my AVR or L1 and so on, going away from AVR and coming towards L1 and so on. So having seen that, so impulse coming towards positive, going away negative, perpendicular is equiphasic. So this is also once again a very important principle you have to remember. Then we have to name the waves. We already know the P wave is atrial depolarization, PR segment is AV nodal delay, QRS complex. The Q is the first negative wave in the QRS complex. The first negative wave is named as Q. The first positive wave is named as R. The second negative wave which follows the R is called S. In some abnormal situation like a bundle branch block, you may have another R wave which is called R dash. In abnormal situation, you can have the second R wave following an S wave which is called R dash wave. Then you have the ST segment which is the gap between the depolarization and the beginning of repolarization, and the T wave is ventricular repolarization. Of all segments, the ST segment is the most crucial segment because all your acute coronary syndromes are going to be in this segment. So of all, we give lot of importance to this ST segment. So depending upon whether the particular wave is big or small, we give either a capital letter or a small letter. For example, you can see it here. My Q wave is small, R wave is small, S wave is small, my R wave is big. So I say small q, big R and small s. So here my R wave is small, my S wave is big. So I give a small letter of R wave and a big letter of S wave. So this is just to name and see. Although you are not seeing the ECG, a friend writes you, my V1 writes a small r and a big S, even without looking at the ECG, you know, in V1, my R wave is small and S wave is big and so on. So like this, you can see it here. We can see it here. It's a small q and big R, so we have given a QR. Here the R and S waves are similar, so we have both are capital letters. Whereas here the R wave is small and the S wave is big, so we give a small letter of and big letter of. So this is an international nomenclature. Depending upon which wave is big or small, you give a capital letter or a small letter. So with this, we finish this first chapter.